Hi, and welcome to our series of conversations about mobility as part of the Mobile People Leverhulme Trust Doctoral Programme at Queen Mary University of London. I'm Kate, and I'm here with Muni, and today we're having a conversation with Aurélie Ponthieu, who works as the Humanitarian Specialist on displacement for MSF in Brussels. Aurélie, could you first tell us a bit more about your role in MSF?
Sure. So, hi everybody. So I'm Aurélie. I work in the operational center in Brussels, and I'm the coordinator of the forced migration team in the analysis department. So that's a department in MSF that provides support to the organization and more specifically to our operations department in terms of operational responses, but also positioning and advocacy. And we are a team of 2 in the forced migration team, and we're looking at, of course, a different context of interventions of MSF, where we provide assistance to population on the move, vulnerable migrants and refugees, with a strong operational focus on the Mediterranean region and Northern Africa and Europe.
Thank you so much, Aurélie, for joining us today. And you talked about the analysis department. So we were thinking, if you could explain to us what's the idea behind the analysis department? Why does MSF have an analysis department, and when was it created?
So I work for MSF in Brussels. So just maybe explain a bit the governance of MSF. There are 5 different operational centers. So one in Paris, another one in Amsterdam, Geneva, Barcelona, and Brussels. And every OC, as we call them, has a different organizations in terms of defining its positioning and advocacy on certain topics. So in Brussels, we have an analysis department. You will not have, a similar setup in other OCs. But our department is relatively new. It's been created 3 years ago, and we are looking at some thematic support. So we have a team working on health politics, looking at issues related to global health and securitization, access to healthcare, vaccination, HIV and TB, to mention just a few topics they are looking at. We're also looking, another team looking at humanitarianism and conflict. Looking at the system of aid in politicized environment, counterterrorism, and its impact on populations and humanitarian assistance. And then we also have my team, the forced migration team, looking at migration and mostly forced migration issues. So yeah, so that's a department that is really looking at transversal expertise to support operations, developing efficient responses, and have good context analysis.
So one of the things that I think is quite specific to MSF as an organization is this diversity within the organization, that there are these 5 different operational centers, and that there's not one unified approach to how MSF works. So could you tell us a bit about the culture of internal debate that goes on in MSF and how that works, particularly around its work with mobile people?
Yeah. So obviously we have a very strong culture of debate, and not only internally but externally as well. So one of the identity of MSF is obviously the speaking out, challenging the other actors, states, but also looking at our role as MSF in the broader aid system. So that's very present in all OCs. That's very much it's very close to our identity and who we are as an organization. Of course, migration has been it's not a new topic for MSF. We've always, the first interventions when MSF was created were, interventions looking at refugee camps, at the needs of displaced populations. So that's something that was very I mean, yeah, very important since the very start of the organization. I think we have evolved quite a lot in our positioning in the last years, especially since 2015, because obviously of the magnitude of the needs that we have observed, especially along migratory routes going, from the Middle East to Europe, or from Sub-Saharan Africa to Europe. So there's been a bit of a wake-up call, I think, in the organization, because not all 5 operational centers were really focusing on this type of project, which are really looking at excluded population in high-income settings. So, richer countries to use shortcuts. But us in Brussels, we always had this type of project. So we already had projects looking at undocumented populations in Belgium, for example, in the 90s. So it's not really a new topic. It's just that maybe these responses now are much more part of our regular mission. And we have evolved as well in terms of, our role in terms of speaking out about the impact of policies. Which created obviously a lot of debates around how much political we could be around these issues that are very, related to migration policies, integration policies, and obviously state responses.
Yeah, thank you so much, Aurélie, for that. I think it's always good to remember that MSF has been created as an organization of both medical and also journalists, right? So, one thing that you mentioned now is that how your scope is very broad, right? So you work both in high-income countries that are destination to mobile populations. You also work in transit routes. You work also sometimes in destination countries that are median or low-income countries. So what are the specific challenges of these different settings, and how does MSF projects vary according to the settings?
It's a very good question, and I think it's actually the type of setting really matters in terms of what type of response you can develop and how you will interact with the state and with the different actors that are responding to the situation. Obviously, in our more traditional settings of interventions, like the traditional, which it's not really well alike because there's nothing anymore, which is a traditional aid response. I think we've moved past that, but you will hear often that refugee camps in Africa are more like traditional displacement settings. I think they present the same patterns of restrictions in terms of freedom of movement, of detention-like conditions as we could find in a reception center in a Greek island. So I think that's should be challenged how much difference there is between these contexts. But indeed, the type of mobility and the access to protection will influence quite a lot how you can intervene as an organization. And you don't intervene in the same way if people are detained, if it's a detention center. Your role as a doctor, and as you mentioned, Nuni, of course, we are a medical humanitarian organization, so we have a very strong medical identity. We provide medical services, so that's and of course it's completely different to offer medical services to someone that is detained than someone that has freedom of movement and is on the move, so is crossing borders. Of course, the exposure to violence also will impact the type of assistance you can provide. Whether people are still, moving towards the destination, their priority in terms of medical assistance will be different. So obviously that has to be taken into consideration when you develop a humanitarian response. Yeah, definitely.
Could we talk about a particular example of one of MSF's operations with mobile people? So, for example, the Musina model of care me and Nooni think is a really interesting example of how MSF has worked as a mediator between different states to provide healthcare. Could you explain a bit how it works?
Yeah, I think one of the the main challenge of providing care to certain people that have specific needs, and especially if you look at chronic conditions, people that need chronic medication, that need to maintain adherence to medical treatment. So people, for example, living with HIV or TB or other chronic conditions. Mobility has always been seen as a major challenge. And for many years, you had a lot of discussions around whether it was ethical or not to actually start someone on treatment if you cannot ensure continuity of care, if you cannot ensure that there will be a medical follow-up, that you will see this person more than once, that you could ensure the person actually adhere to treatment for months, to start someone on a treatment that is for life, for example. So that's always been a discussion. Also in the humanitarian field, at the very early stages of the start of the response to the HIV/AIDS epidemic, and for MSF as well, was a big debate whether we could get involved in lifelong interventions. And we moved past that. We are very we have a very prominent role in HIV responses, and the Musina model of care, which I think is very interesting because it basically tackled this idea that mobility doesn't mean you cannot provide care to people that have these chronic conditions. You have to integrate mobility in the care you provide, and you need to adapt to it rather than see it as an obstacle. So Musina is a small town at the border between South Africa and Zimbabwe, where it's a major crossing point for people entering the country. And that's a place where we actually set up a project. At the time, then there was this mass influx of Zimbabweans fleeing different disasters from Zimbabwe. So there was a cholera epidemic, there was economic collapse of the country, and people for survival had to go to South Africa to find jobs. And the Musina model of care has been obviously developed in a context where there's very high HIV prevalence among this population. So we were developing these mobile clinics in the farms around the border. And we actually adapted the HIV response to the mobility of the farm workers. And there are basic principles, which is basically to make sure that you integrate mobility. So you have conversation with the patients about their plans. And the more predictable mobility is, obviously, the easier it is to provide proper counseling. So counseling is very important. There was a roadmap as well. So basically people were telling us, I am planning to leave this farm in the next 3 weeks, but the person needs, chronic medication. So you will basically tell them how to adhere to treatment, what to do if they have to interrupt treatment. We'll give them enough medication for 3 months so that they have sufficient stock of drugs to make sure they can continue their treatment. You tell them where to seek care. So there's a roadmap where you can find other health structures that provide access to testing, but also medication, ARVs in this respect. So that's really basic principles behind how you can integrate mobility in the care you provide to people living with HIV.
So one of the things that we were thinking about in relation to this is the ethics of collecting data about mobile people. So firstly, there's the issue of asking them about their plans for mobility and whether people are willing to say that. And of course, there's the doctor-patient relationship, which I think helps in terms of building trust with people, but also about the ethics of collecting data on people and their health across borders, and what are the difficulties with that. And I think the health passport, which was developed as a part of this model, where the health information travels with the person rather than in a database or outside of the person's control is a way of getting around this somehow?
Definitely. Patient health record is key to continuity of care. And that's a major concern for people who are on the move. People that are, trying to cross borders and know they have, they have a sickness that needs to be treated. And indeed, there is, of course, it depends on the context, right? But in the context where we intervene, there are policies trying to prevent people from moving. There are policies that criminalize, this type of movement. People are forced to move in an irregular way. They are undocumented. So obviously having this conversation, which is very important, even, as you mentioned, doctor to patient, that is of course a confidential consultation, but you need trust. You need to make sure the person will not think that you're going to report to the police or you're going to deter the movement. So we have to build trust and to have to build, this relationship where it's okay to say, I'm moving irregularly. I have found a smuggler and I'm going to Germany to, so that's of course a trust that you need to establish, which is very challenging, especially if you're not, if you don't see people many times, like in many of our projects, where people are in transit still, you see them maybe once or twice, but this, this first consultation is key. To give all the information that is needed and to be able, to find, the person, a network of assistance on the route, to have, basic information provided in terms of where to seek care, what is the emergency number the person needs to call if something happened, also raising awareness about the fact that the person needs chronic treatment. So of course, there are tools that exist for like the health passports. It's very basic information about what is the treatment the person takes, what type, of other essential medical information that will be very important for another doctor to have when the person will seek care again. So that's very, very important.
Haiti, in these cases that when you were thinking of this idea of the health passport, you would need the compliance of all the governments involved, right? So the governments for example, in this case of Zimbabwe and both South Africa, they would need to share this information somehow. And what are the challenges of having to share the patient data with a different government or different health ministries of different states?
So obviously, in an ideal world, we would have, state responses across borders that would facilitate this access to medical information, this continuity of care. And that will be a major concern for states to actually ensure continuity of care, because we know, and especially looking at the HIV pandemic, of course, in terms of public health, if people don't adhere to treatment, it doesn't make any sense. So it will, of course, it is in interest of public health authorities to ensure people adhere to treatment, continue the treatment, and then are not transmitting the disease across borders. So that would, of course, will be something that we would expect governments to take as a priority. But indeed, and looking, and going back to your questions about the data collection, like how much data we can have and we can collect, and how ethical it is, I think the lack of data about, mobility, especially mobility related to healthcare, which is not all, in many regions, not the major reason people are crossing borders. There are many other factors that influence the decision to move, but you had a few contexts where it's very important. It plays a big role, that people actually seek care across borders. And in the southern African region, it's very, you have people crossing border every day to seek care, and especially ARVs, HIV treatment. You also have that in Venezuela. One of the main reasons for people to flee Venezuela has been to seek medical care. So you have a lot of people with very severe sickness actually leaving the country for care. And that's something that is very, disregarded, also because there's no data available on these movements. And a lot of people are forced to move, in an irregular way, undocumented. So they are not, reporting themselves at border. So there's no official data existing on this population. And most of the data that is collected today by governments actually is used to deter or limit migration rather than the opposite. And we know that if this is, very important when you look at the data that exists along migratory routes. There's a very big focus about, security and control rather than adapting then, public health responses to these movements.
So we've talked about continuing healthcare across borders and how that's difficult. What about in situations where migration policies and borders themselves are causing health problems? And how does MSF choose whether and how to intervene in those situations?
Yeah, and it's actually it's one of the main reason behind most of our interventions today in migration settings, and in most of the projects we have. Of course, if you look at more challenging environments in terms of resources, like if you take a refugee camp, in South Sudan, obviously, most of the needs are going to be related to the lack of capacity of the local authorities to actually, accommodate the new refugees, to respond and provide services. This is absolutely not the case in Greece or, in Belgium or France and other countries where we work today. It's obviously not an issue of resources or financial means to provide assistance. It's really, we are really responding to humanitarian and medical needs directly related to policies and to state responses that are aiming at deterring these movements of populations rather than, reception and protection. So obviously that's where you find this tension I was mentioning, early on in the discussion about the politicization of the topic. How much, how far can you go as a humanitarian actor with your humanitarian principle in actually addressing the root causes of what you see, which are not lack of resources, lack of capacity, or people coming, with already sick to the border. Most people actually come quite healthy. They are pretty traumatized for sure, but their health clearly deteriorates when they arrive after several months being stuck in inhumane living conditions in a center at the border in the Greek islands, or living in the streets harassed by the police on daily basis in Belgium or France, for example.
And Aurélie, I know that in a lot of these situations you face like the difficult question of whether you should speak out as an organization, or areas like speaking out would actually jeopardize the care, the assistance that you can provide to migrants and refugees. So can you tell us a bit more about this dilemma and how MSF deals with that? What are the aspects that you need to take into consideration?
So, of course, in MSF we have, it's part of our identity to do what we call témoignage. So it's a French word, but that's, every single person working for MSF actually knows. And it's about speaking out. So it's really, we of course our main objective is to provide medical and humanitarian assistance, but we also equip ourselves to be able to denounce situations that are unacceptable, and to also point fingers at those responsible for these situations. So MSF has a long history of speaking out against different policies. We've been very prominent on certain medical issues, denouncing lack of access to essential medicines, and trying to really push for every single human being to have the same chance to receive healthcare everywhere we work. But obviously, this always has to be balanced with, being able to continue our mission, which is assisting people So we are there, and we are an emergency organization, so we save lives, and that's always, the most important thing. So we will always have to balance, our advocacy or speaking out with our ability to continue providing assistance. So that's always an exercise that you need to make. And there's many ways of, addressing states, addressing their failures and pointing at the root causes of the problem without jeopardizing your access, without jeopardizing your staff, your security, and the security of your patients. So that's always, an exercise that needs to be done. And obviously, it's sometimes easier to speak out in certain contexts than others, depending on the relationship you have with the states, or how tolerant they are with being, shamed about their own responses. Obviously, it's easier to speak in Europe than to speak in other countries where MSF will face much more problems. So that's always, that's part of the difficulty, but that's the reality of this world. So that doesn't mean we should not speak out in the places where we can.
And as I understand it, the moment when MSF chooses to withdraw from a situation is also one of those ways of kind of drawing attention to what's going on and showing how MSF is filling a gap that's somehow left by the state. Can you give us an example of a case when MSF has withdrawn from a situation specifically to say, we can't do this anymore?
Yeah, obviously, part of this exercise of, balancing between speaking out and responding is also what impact did you have. And in very rare occasions, it's not so often, but it happens, and it happened in our history. You sometimes reach the point where you cannot do anything anymore. Like, it doesn't make any sense to continue, providing care to someone that is going to be killed at the door of your consultation room. So when you reach these limits where you know that you have no other means to help, that's where you have to take the difficult decisions then to either withdraw or speak out, and in a very, very strong way. So these are very rare occasions, but it happens, unfortunately. But there's few very well-known examples, but one I know very well because I was involved in this process was, for example, in Libya, when we withdrew from the detention centers in Misrata because people were being tortured. These were war prisoners that were tortured, and we were providing medical care inside these places. And we started suspecting people were being tortured outside of the detention centers and brought back to be treated by us. And the signs of torture became more and more visible, and we really started to be very, very uncomfortable, obviously, with the role we were asked to play, and we had to denounce the situation and obviously stop intervening in these places. It's always very difficult because you still leave people behind. You still leave your patients behind. But of course, there is also a moral duty not to do no harm, which is one of the main principles of humanitarian organizations. We always have to assess whether we do harm or not, and there's sometimes very thin lines to determine whether you're doing harm or not. And that was very clear-cut case where we could not stay.
And Aurélie, I think one very effective way of speaking out and also of improving our the intervention, as you said earlier, is by collecting data, right? Mm-hmm. You emphasize the importance of that. But at the same, and I know that MSF is one of the organizations that most often conducts operational research. And I know as well that there are many challenges in conducting operational research in settings where you're also providing health assistance. And one of the things that I learned while working at MSF is to always think of the question, how much do we need to know? And I think that's a very particular way of thinking within the organization. So could you tell us a bit more about that? And yeah.
No, obviously, because we're also a medical organization, so a lot of the information we actually collect is protected by medical confidentiality, and we care very much about the respect of medical confidentiality and medical ethics. So that's really something that we will never compromise on. And obviously, another aspect is also security. We're also intervening in very sensitive environments where, having too much information sometimes can be very problematic. So we always have to make sure that, if we collect information, we know exactly for what purpose it will be used, and that we ensure that we don't put anyone at risk with this information. So we have a very strict policy in this regard, but we also want to make sure that we also have, positive ripple effects of what we do. So if we can, draw lessons and learn from mistakes or learn from successes as well, and then be able to promote that elsewhere, that's a very important role we can play as well, because in many places we are the only medical actor. We have the resources sometimes to also innovate, develop models of care that can, as you mentioned, the Musina model of care, that many health actors could learn from, and also other MSF missions, which is also very important. So that's a very important process. So it's again, an exercise of making sure you weigh the pros and the cons of your data collection in full respect of medical ethics, medical confidentiality, and other ethical concerns and safety concerns. But that's always part of what we do. And for advocacy reasons, we need data. We need to have more than medical information, medical statistics. It doesn't really talk to key stakeholders if you just bring your statistics of how many people have scabies, or have had this type of disease, or so you need more than this. So that's why we have people like us that can help the operations actually develop the context analysis and data collection system.
I've noticed that MSF also has a lot of testimonies from people who they help. So does that come under témoignage? Is that part of the speaking out? And do you think that the qualitative data is as important as the quantitative data that you collect?
Yeah, we do testimony collection indeed, and I think it's evolved over the years, because obviously at the start of the organization, the role of témoignage was mostly to actually be able to bring information to the external world. We were talking about conflict or crises that were not known, where there were no images, there were no one going to these places. So we had a very strong role to play in actually exposing the truth and talking about what we had seen as volunteers in these situations. Obviously now it's a completely different role that we're playing, but we still believe that our own analysis of situations needs to be brought up as well, and that we have a role talking to the UN, talking to states, but our patients as well, they have their voice, and more they have their own communication means, social media. So of course testimony collection was very much a tool where we could give visibility to people's stories, like they could, with their own words, tell their own reality, and that's something that is very important. So I think we are doing less of that today, because our patients have Facebook pages and social media. They can talk to journalists. Journalists are everywhere. They come every day in Lesbos. I mean, we can have our own analysis that is going to be very different than maybe some other person, but that's still very important to us that we hear what our patients have to say, so we can contribute to that in a way. So testimony collection obviously is a part of it, but but it's less and less, I think, important than before. Now we need to make sure people can speak for themselves because they have their own voice. They don't need MSF to speak for them.
Yeah, that's very interesting, Andy. Thank you for drawing that. And just to finalize, since you were talking about people like having their own voice, could you tell us a bit more about any new approaches that MSF is designing that is more, because we know that a lot of times humanitarian organizations have been criticized for being very top-down. So are there new approaches that you're thinking specifically targeted at mobile people that kind of do it differently, more from the ground, from the people, and so that they can state their own problems?
Yeah, so we have, so it's, I think it's work in progress. So obviously, that's really something we want to develop more, but we are piloting in one of our projects, actually in Greece, again. In our clinic in Athens, we have a clinic that focuses on offering rehabilitation services to survivors of torture. So in this clinic, we have developed a project that actually is, I mean, it's not something that has been developed by MSF. It's something that exists in other organizations, and other organizations that are specialized in rehabilitation of survivors of torture have been doing for years. It's called Expert by Experience, and that's something we know from the HIV and TB field as well. Patients being advocates for better access to treatment, or offering peer support to other people who are living with the same conditions. That's something that is very, that's not so new for MSF. But this specific pilot component in this clinic is really more based on advocacy. So it's really a group of patients that is developing their own advocacy objectives as survivors of torture, looking at how they can influence their policies, and MSF facilitates the group, they facilitate training, and then we really want them as well to contribute to the development of our activities, to provide feedback in terms of the care we provide. Is it good enough? What can we do better? Are we responding to the needs? And how we can be complementary as well with our own advocacy objectives around migration policy in Greece. So that's something that I think is very interesting, and that needs to be looked at a bit more, and that we could potentially do a bit more everywhere as well.
I have another question, which is related to the pandemic and the increasing restrictions on movement related to, like, especially across borders. I wondered how MSF sees this, and whether I think there's a danger in this situation that mobility itself gets problematized and pathologized and becomes the reason for the spread of COVID, when it might not necessarily be the case that cross-border movement is the problem. How does MSF see this?
I think it's a key issue. It's a very good question. I think of course there are different phases. If you look at mobility in this pandemic, we've seen mobility being obviously seen as the problem. So, and that's for good reasons, because indeed, and we were very scared at the beginning that migrants will be criminalized even more, or accused of spreading COVID, and we have seen very clearly that it's not not migrants who actually were the main factor of transmission, but more rich businessmen traveling the world for their work, so or tourists. So that's clearly another type of mobility. But indeed, we've seen in some instances and in certain countries, governments using the pandemic to actually push their restrictive migration agenda even further. So we've seen discriminatory practices. We've seen and with very bad consequences in terms of human rights, but also in terms of consequences directly on the lives of refugees and migrants. If we take the example of the Moria fire, that's very much linked to the lockdown of the camp and the very bad measures that were implemented in the camp for COVID. So there is this problem, which is conflation of migration control agendas with public health, which is a disaster in terms of, again, the trust of a certain group of population towards health actors and health authorities. We know, and because we are experts in outbreak responses, and in other places we've seen how difficult it is when you don't have this trust between the population and the health authorities. Thinking about Ebola response in DRC or in Liberia, in other countries where you really need this trust if you want to actually really stop the outbreak. And then the second aspect is going to be, disruption of mobility, of course, exposing people to further risks, to further dangers, the people who are going to be stuck in places they should be living, if they want to save their lives. And then, of course, the ripple effect of the pandemic in terms of economic realities, survival, coping mechanism, remittances. So we can only expect, mobility becoming again, one of the main chance people will have actually to make a living and feed their families. So we can only expect more movements that are, forced by the realities that people are facing because of the COVID pandemic, and we already start seeing some signs along certain migratory routes that COVID is pushing people to leave. People who were not living before, who are now, having to migrate because of poverty. So yeah, so many aspects related to COVID and mobility that needs to be looked at and analyzed better in the coming months.
Thank you so much, Aurélie. I think we could go over, we could have even another meeting to talk about COVID, mobility, and MSF. But thank you so much for agreeing to joining us today. I don't know if you have any further questions, please.
I think we've run out of time, sadly, but thank you so much. I think we'll have a lot to discuss afterwards, and thanks so much for coming.
Thank you for having me.
We really appreciate it.